too, and we're happy that you are able to join us for this session. So I'll hand it over to Joseph, who is our moderator for today, to walk us through the session.
Okay, so hello everyone. My name is Adedaya Joseph, and today we're going to be talking about integrating prevention and early detection systems in healthcare, in cancer care. And we have three people who are going to talk to us. So we're going to talk from perspectives of work that they've done and really give us a real world understanding of how this should work, how it has worked, what difficulties you might face, and how to overcome those difficulties. So because we're a little past the time already, I'm just going to, go forward. And I think we're beginning with Dr. Anna Cabanes. Are we? Okay. And so Dr. Anna is a cancer epidemiologist who's been doing this work for a very long time. She's worked at Georgetown University in the USA. She's a well-known name, an epidemiologist with more than 20 years experience in the field. She's held positions in cancer research, cancer surveillance. Between 2011 and 2020, she led community health programs in the US and internationally at Susan G. Komen. Everyone knows Susan G. Komen is the largest nonprofit dedicated to breast cancer in the world, I think. She's worked with patients, advocates, healthcare organizations, governments to innovate and integrate new cancer programs within healthcare systems, to develop national policies and establish successful care delivery models, and to mobilize communities through evidence-based advocacy. So more recently, since May 2020, she works independently, assisting organizations to develop and implement cancer programs. She's currently senior advisor at Global Focus on Cancer, focused on integrating cancer supportive programs in healthcare systems. So thank you very much, Dr. Anna, for talking with us today.
Thank you, Daya. This is great. Thank you for inviting me to this discussion. That it's about a topic that I'm really passionate about. So the echo structure, it tends to be, or it is a didactic presentation followed by several or one or several case studies. But what I would like to do today is more of a food for thought session, where I'm going to present here some ideas, some things, and then I hope this will, with Songiso's presentation and Lydia's presentation, will stir a little bit of a discussion. So the outline is, why is integration needed? What are the core elements of these programs that are integrated, and what are the variable elements? And then a little bit of a summary. So you've seen these map probably several times. This is incidence rate. This is the top cancer according to incidence rates in all these countries. Then if we do, so you basically see that it's either breast or is cervical cancer incidence, the top cancer in these countries. If we look at the mortality rate, so this is basically the same thing, we see again that the map is just cervical and breast. We do have more cervical for mortality, but still we have a combination of the two. And actually, if we look at the countries where breast cancer is the top cancer, we would see that cervical is the second one. And if we do the opposite, the cervical being the top, then the breast would be the second. So what we have here, what's happening is that we have a double burden of female cancer mortality. And it's not really, it is important, but it's not, the question is not it's breast cancer more or cervical cancer more. For me, the main issue is that if you add the proportion of deaths that are attributed to breast cancer and to cervical cancer in all these countries listed here, and this is not a comprehensive analysis, this is just looking at GloboCan and adding the percentages, you'll see that that breast and cervical cancer together account for more than half of the cancer deaths in females in all these countries. So this is really something that I wouldn't say unprecedented, because we've seen in other regions, we do see this double burden, but really what it happens with this double burden is that this poses a huge challenge to health systems that they're already, they're not perfect. So that adds one more thing that they have to resolve. This is basically just prevents human development, and with, you know, with all the consequences of losing women and the middle of their lives and leaving their families alone, et cetera, et cetera. So, you know, I would say that this is the main argument of integration, that really we have health systems that cannot absorb or cannot manage to have parallel, to have two vertical programs, one for cervical and one for breast. And while we understand that the two cancers are different, because cervical cancer do offer a couple of very clear points where you can intervene and prevent the appearance, the development of cancer, while breast cancer cannot do that. But they both, for example, they're much better if you detect them earlier. So looking at what are the points during the continuum of care or the course of the disease that we can intervene and be more efficient and do both at the same time, I think it would benefit not just the health system, but also women. At the end of the day, this is what is important. So I wanted to show you this. This was 10 years ago. I did an analysis of breast and cervical cancer mortality in Latin America. These are not exactly the same graphs that are on the paper. This is from the Global Cancer Observatory. But you see that in these two countries in Latin America and in different countries in that region, you see that, that the mortality rates for breast and cervical cancer, the trends, the two lines cross. So to a certain extent, we could say that by the time that breast cancer rates started to increase in this region, that cervical cancer was already in the way down, which to me, you know, kind of shows that at least these health systems got a little bit of a break, that they didn't have to really deal with that double burden for a very long time. I couldn't find, GlobalCan doesn't offer these for the countries in Africa. I couldn't look at the trends, or I couldn't look at the easily, right? Because this is, you know, I want to also say that this is a very crude analysis. It's just to kind of, you know, understand why these double burden but anyway, but I couldn't find the numbers for Africa. But what I could find, I could estimate into the future, you know, if nothing changes, what would happen. And we see that crossing of the lines in not happening now, maybe a few years from now. And again, you know, this is data combined for all these countries. So there are going to be some countries in sub-Saharan Africa that they're already, you know, that they're already, cervical cancer is already in the way down, but a lot of countries, they'll have to live with this double burden for a long time. So the good news is that many groups are already implementing breast and cervical cancer early detection together. And we're going to hear today from Zambia, from Sungiso right after me. Then Lydia, I think she'll speak a little bit about Rwanda, but there are also initiatives in Cameroon, in Botswana, and in Kenya. I just saw an article published recently in the Journal of Global Oncology. So, and again, you know, this is not a review and a systematic review. This is just the people that I knew that they were doing work, but there's people in the ground doing this type of integration. So what I think we don't have is we haven't had the time to really sit and look and discuss what are the commonalities among these interventions and what are the things that are different, because they have to be different, because obviously they're being implemented in a different setting and in a different healthcare setting as well. Not all of them, they're meant, the variability here is, I think everyone does a different thing. Zambia is a breast cancer clinic where they're going to include cervical cancer, whereas in Rwanda is the opposite, is cervical cancer screening, where there is an assessment of symptomatic cases for breast cancer, and Lydia will explain more. In Cameroon, it's again a breast cancer program that added cervical cancer. So there is a huge variety. And if today I wanted to implement something similar in Washington, DC, I would have to go and talk to all of them, because I could probably not find some kind of, there are no guidelines, or I don't want to say guideline is a little bit too serious, but there is no paper that I could read and would tell me, hey, this is what you need to do and this is what you can change. So, so this is what I thought I would do today. I would put these up here for discussion, because I think that those are maybe the excuse me, the components that would be more important if we wanted to replicate or we wanted to scale this intervention. So what is integration, right? What point do we want to integrate? Do we do it together? It might be different for different programs, but we need to really understand and see the feasibility, whether it's really possible to integrate at the point that we want. What are the core elements that are necessary that you know, yes or yes, you must have those elements? And what are the ones that they can vary because it's a different context, and really you need to tailor your intervention to the context. And then the barriers and facilitators. So the core elements that I think, again, this is my my opinion, right? That can be completely, I could be completely wrong, but I think to me, two core elements are: one, the trained healthcare professionals. There is no way you can implement the intervention if you don't have somebody understanding or knowing how to do cervical cancer screening or breast cancer clinical breast assessment. And then to have a referral path. No matter what you do, the referral path has to be there, because all these interventions, or most of them, take place at the primary care level, and you really need to refer these patients to doctor. The low levels, they don't really need to understand, but really the referral path has to be very clear, so that patient doesn't waste any time. Now, the variable elements are, you know, depending on you're starting from breast or cervical, and also you have to take into account that breast and cervical, again, are not the same disease and they have very different features. You need to understand your community. I think cultural elements, maybe there is more stigma for breast than cervical cancer. In some cultures, maybe the breast, because of the looks and everything, it carries a larger stigma, maybe not, maybe cervical cancer. So really understanding this, the screening protocols of the country, you know, what are the ages? You need to really, because those are the ages that you're going to get coming into a cervical cancer program or breast cancer program. The level of the health facility will determine how many things, or the availability of some services and machines, if you want. And then in general, the health system features, right? Again, you know, even having all these on paper and having design and having thought out this through very well, you then can find barriers and facilitators that that will modify all these. So in Washington, D.C., for instance, I would say that even if I consider everything, that, you know, a barrier could be the health insurance for women. So really thinking, for me, these 4 points are, you know, they kind of, it's a way of really thinking through the planning of the project. So in summary, many groups are already implementing breast and cervical cancer early detection or screening or some kind of modality, but in that early detection phase together. So really, you know, I couldn't encourage them more, you know, that they need to get together, put their heads together, and see what are the, you know, what are the things, the commonalities, the differences, and really make this public, disseminate to other practitioners. There are opportunities now currently, the cervical cancer elimination strategy from WHO, Global Breast Cancer Initiative that's being also developed with WHO, and the emphasis that it's being put on people-centered care with services organized around the needs of the people rather than the individual diseases. And finally, I want to call attention, or I want to say that information is needed for implementers, right? If whoever wants to replicate, scale, but also there is, you know, an extreme need of information for cancer advocates. You know that in a lot of people, in a lot of countries, advocacy, and there are not a lot of cancer advocates, and the few that they are, they only advocate for their own little niche. And sometimes that little niche, it's not even the most, I would say, the most pressing need for that context. So, having this information out there and maybe developing some information for in lay language for people that are not public health professionals would also help to be more coordinated, not just at the level of implementation, but at the level of cancer advocacy. So that's all for me today. I hope, I really look forward to the discussion later. This is my email. Feel free to email me. And thank you again. Over to you, Dayo.
Okay, so thank you very much, Anna, for a stimulating session. If you have any questions, please put them in the chat. And while we're doing that, we're going to go on to the next speaker, Dr. Mutumba Songiso, who is a specialist general surgeon who completed a general surgery training in the University of School of Medicine. So he attended his fellowship in general surgery with the colleges of East, Central, and Southern Africa in 2016, and the breast surgery training in 2017 in South Africa. He's passionate about finding ways to achieve early diagnosis of breast cancer and reduce the delays patients face during their treatment journey from presentation from the first onset of symptoms to treatment. In March 2018, he was part of the team that set up a specialist breast care clinic at district level hospital, which happens to be the first of its kind in Zambia. So welcome, Dr. Mutumba Songiso. Thank you for speaking with us today. Dr. Songiso, you're muted, we can't hear you.
Okay, thank you very much. I'm going to turn off my video so that I can preserve my bandwidth. Let me just try to go back. Okay, so thank you very much. I'm going to present our little case from Zambia. So I'm just going to give you a brief background. According to GlobalCan 2020 statistics, breast cancer and cervical cancer in Zambia combined account for 52.6% of the new cancer diagnosis, and also account for 52.4% of all the cancer-related modalities, which is very high. And we know for breast cancer, most of the patients present in late stage, and that adds to the low survival that we see in this region. And according to a report which summarized 83 studies and across 17 sub-Saharan African countries, it shows that the patients who present to the hospital with a diagnosis of breast cancer, 77% present in stage 3 or stage 4 disease. So for cervical cancer, this is the most common cancer in Zambia, and in other countries, high-income countries, it's usually maybe the second or maybe even further from the first. This is because good strategies have been implemented for screening and there's early detection, and usually the mortality from cervical cancer is usually very low. And for Zambia, we're trying to follow suit, and hence there was the cervical cancer prevention program, which was introduced in 2005 with the help from PEPFAR, Global Fund, and World Bank. And this was implemented using a single visit VIA, visual inspection with acetic acid, which is followed by cryotherapy, thermocoagulation, or LEEP, depending on the lesion which is found. So the woman is screened and treated in the same setting. And this program has screened over 600,000 women so far and has treated over 20,000 pre-cancer women. So currently this program is robust, and it is almost in all the, let me say it is in all the districts in Zambia. We have more than 150 facilities, and the network keeps on growing. And this program has been adopted by the Ministry of Health since 2015, and currently the Ministry of Health are the ones running it. And there is a training program for providers. And in the training program, we have included clinical breast examination, just so that clinical breast examination can be done on these patients who come for cervical screening, since we've realized that it's the same patients who come for cervical cancer screening who need clinical breast examination. So as for breast cancer in Zambia, this is the second most common malignancy in females, and it has high mortality. And the reason is usually due to late stage presentation. So most of the patients, the majority of the patients who present in stage 3 and stage 4. And we know now that in our setting, women present quite early compared to the US, where they present around 62 years of age. So we looked at the barriers to early detection, and among them is low levels of awareness. And this awareness is not just for the patients, or rather the communities. It is also low level of awareness concerning the healthcare providers, because we see at the low levels of care where we don't have medical officers, and we rely on what we call clinical officers, who are physician assistants. Some of them will be not aware of breast cancer, and in the process will misguide the patients who initially presented early to our health system, which has multiple levels of care for someone to reach where they can get help, especially concerning breast cancer. So we have also noted that it's very different, like Anna mentioned. Breast cancer and cervical cancer are very different. For cervical cancer, there's an opportunity where you can do either the HPV testing, or maybe you can do VIA, and you can see the lesion which can be treated. And this program is basically run by nurses. On the other hand, for breast cancer, it's a bit more complicated, because it will require ultrasound to be done. It will require a core biopsy to be done. It will require a lab to analyze that specimen. And usually these labs are centrally located, and the facilities which are able to offer core biopsies are also centrally located, which makes it very hard for patients who are in little corners in villages to access these services. As a result, even if they were aware that something was wrong in their breast, it will be very difficult for them to reach a level where they can have appropriate care. Just to give perspective to what I'm saying, I'll show you a slide with the referral system that we currently use in Zambia. So we have primary health care, secondary health care, and tertiary health care. So for primary health care, the patient will enter the system either through a health post or a health center. Then they'll be referred to a level 1 hospital. So a level 1 hospital is basically a district hospital, which refers to a level 2 hospital, which is basically a provincial hospital, which also refers to a level 3 hospital, which is a tertiary hospital. So a level 1 hospital in Lusaka would refer directly to a level 3 hospital, because Lusaka doesn't, which is the capital city, doesn't have level 2 hospitals. And a level 1 hospital, usually you wouldn't find a surgeon there. You'd find a medical officer, a general medical practitioner, but not a surgeon. And some of the level 1 hospitals, which are district hospitals, you wouldn't find a facility, or rather maybe most of them, you wouldn't find facilities where someone can perform a core needle biopsy. So looking at these problems which are in the healthcare system and the delays which the patients face, or the late stage in which the patients present, in 2018, with the help of Susan G. Komen, we established the one-stop breast clinic, which is in Matero, that is in Lusaka. And this clinic is run by 2 surgeons. And when we started this program, we created the demand for these breast services through the cervical cancer platform. So all the cervical cancer screening nurses were trained in performing breast cancer, clinical breast examination. So these nurses could detect, and if they detect that the patient has a mass, or maybe a patient goes for cervical cancer and mentions that they have a breast lump, they would easily be referred to this breast clinic. And additionally, in Lusaka, which is the capital city, all the health centers, or all the level 1 hospitals which are in Lusaka, were informed to refer these patients who have breast symptoms directly to the Matero Breast Care Clinic. And in this clinic, what is offered is the clinical breast examination, breast ultrasound, ultrasound-guided core needle biopsy, and for surgical management, the clinic is able to do mastectomies, axillary lymph node dissection, and white local excision for selected patients. And this clinic runs on a no appointment basis. So it has 2 clinic days. And on those clinic days, a patient can simply walk in and be seen by a specialist. And if they have a suspicious lump, the same day, that lump would be biopsied. So this is just a diagram to show how patients flow to the Matero Breast Clinic, which is in a level 1 facility, which is like a district level hospital. So patients from health centers within the Matero sub-district will move in without a referral to Matero Breast Clinic. Patients from other level 1 hospitals within Lusaka would also move in to Matero Breast Clinic, and also patients from the cervical cancer platform. And at this clinic, a diagnosis will be made through a core biopsy. And when these patients are diagnosed to have breast cancer, they will be staged. If it's stage 3 and 4, they will be referred to the cancer disease hospital. If it's stage 1 and 2, maybe surgery will be done. And after surgery, they will still be referred for chemotherapy and radiation. And if they were 3rd and 4th stage who were referred for neoadjuvant chemotherapy, they will still be sent back to Matero Breast Clinic for their surgery. So I just wanted to show the results that we've seen from 2018 when the clinic was established. So at the end of year 1, we had a total of 63 cancer patients. And of these, 28.5% were early breast cancer. At the end of year 2, the total number of patients was around 112. And of these, 37.5% were early breast cancer. And currently now, we have about 276 patients. And of these, 45.7% are early breast cancer. So you can clearly see that the proportion of early breast cancer has been increasing. And we are hopeful that by the end of year 4, we'll have maybe 50% or even more. And by the end of year 5, we should have more early breast cancer compared to late stage 3 and stage 4 breast cancer. So, and also to add, we've also introduced, sorry, I can't move my slide. I don't know what is happening. Okay, so currently at Matero, we've also introduced a new study which has been supported by the Fogarty International Center and the NCI. This is a study where we are implementing a one-stop mega clinic for HIV and women's cancer. So in this program, we are doing HIV self-testing, HPV testing, and breast assessment. So the patients don't necessarily need to go to the cervical or cancer screening to have their HPV testing. So they do it at just at the same time as they are doing the breast assessment. So this we believe will cut down on the cost that the patient have to bear moving up and down in our health system. And this is a very good, we feel it's a very good for integrating our services. And we know that in our environment, the resources are very scarce, and if we scatter them, it becomes very difficult for us to achieve something. And from that clinic, which is made in Lusaka, and hopefully we're going to replicate this clinic in all the provincial hospitals. And we are very hopeful that if that happens, we'll have more patients present with early breast cancer. And I'll end by saying we need to look, find, and treat all palpable breast cancer before we even think of non-palpable breast cancer. Because if we rush to think of non-palpable breast cancer without establishing proper channels in which palpable breast cancer can be treated, then we'll be failing. We'll have more patients with diagnosis, but that we cannot handle in our system. I would also like to acknowledge Susan G. Komen for setting up this breast clinic and also replicating it in the southern part of the country. And I would also like to thank the Fogarty International Center and the NCI for the grant that is supporting the current project that we have. Thank you very much.
Thank you very much, Dr. Songi. So that was a very interesting conversation, interesting presentation, showing how you can actually integrate the systems and have it work. We're going to have Dr. Lydia Pace next. I just wanted to mention, so some of the things that you talked about with regards to healthcare professionals, for example, is one of the things that we found to be really important, because we tend to blame the patients for delayed presentation when sometimes the healthcare system is what's really failing them. And they've seen who they think is a healthcare professional, but the person doesn't, diagnose them or refer them as appropriate. Lydia, I see your comment talking about these are really, really promising and impressive findings, Songi. So would love to get your thoughts on the factors that are most contributing to the increase in early stage diagnosis, e.g. increased awareness, reduced community delay, decreased system delays, decreased referral delays, exactly, or a combination. So Songi, do you want to think about that while I introduce Dr. Lydia Pace, who is an associate physician in the Division of Women's Health and General Internal Medicine at Brigham and Women's Hospital, and an assistant professor of medicine at Harvard Medical School. She practices primary care in the Phyllis Gen Center for Primary Care and cares for women at increased risk of developing breast cancer in the Brigham Women's Hospital Breast Cancer Personalized Risk Assessment, Education, and Prevention Program, the BPREP program. So Dr. Pace is a clinician investigator who is focused on advancing equity in women's health service delivery and policy, both in the US and globally. Since 2012, she has worked with colleagues in Rwanda on strategies to facilitate breast cancer early diagnosis. Hi, Lydia, welcome.
Hi. Okay. Are you seeing my screen now?
Yes, we are.
Okay, great. Thank you so much for having me. I really can't overstate what an honor it is for me to co-present with Anna and Sangiso. I am such an admirer of their work and accomplishments. So I look forward to sharing with you some of our work in Rwanda, which has been trying to address a lot of these challenges that, that Sangiso and Anna both described. So this is Rwanda. I haven't been there since before COVID and I miss it terribly, but had the great pleasure to live there for 3 years and have been working there since 2011. So I wanted to just start by telling you a little bit about a breast-only intervention that we implemented in one district of Rwanda. So very similar to Zambia and elsewhere in sub-Saharan Africa, our individuals, or our patients with breast cancer, the majority of them were presenting with stage 3 or 4 disease, similar to the data that Sangiso presented. 75% of our patients were stage 3 or 4. Our median age was about 51, and this was at Rwanda's main cancer center, Butaro Cancer Center of Excellence. So we implemented an intervention in one district of Rwanda, the district surrounding the Rwanda's first public cancer facility in the rural northwest of the country, which was Butaro. And this was a breast-only intervention focused on early diagnosis of palpable findings. So based on a principle very similar to what Sangiso was describing, that we first need to decrease delays experienced by women who have breast symptoms, because we know that they were experiencing unacceptable delays. So we trained community health workers to provide communities with messaging around breast cancer, signs and symptoms of breast cancer, as well as treatability of breast cancer and the affordability of breast cancer care. At our hospital, we're able to heavily subsidize breast cancer treatment so that the cost of actual treatment is relatively low for patients, though not zero, and that still is a burden for some patients. We also trained primary healthcare nurses who staff the rural health centers to do clinical breast assessment, which entailed assessing symptoms, doing a high quality clinical breast exam, and then we provided them with algorithms for who should be referred immediately to Butaro, to the hospital. And then we also launched a breast clinic at the hospital that did diagnostic breast ultrasound and core needle biopsy, sometimes in the same day, though often over the course of 2 days. I absolutely agree that having a one-stop visit is the ideal. But we did find that this program had a profound impact in terms of increasing the number of women who are presenting to health centers with breast symptoms. So this graph shows the number of patients per month coming for a breast concern. We randomized health centers to receive the intervention. So the dark blue line shows control health centers. The two other lines show the increase in volume that happened after the trainings in a first group of health centers and then a second group of health centers. We also found an increase in the number of patients who were referred to the hospital with breast symptoms, an increase in biopsies as well. Increased referrals in the intervention health centers compared to the control health centers. The women who were seen were quite young. So the median age was 30. But the median age of those diagnosed with cancer, which I don't show here, was still about 50, which is similar to what we see at Butaro overall. And we did find that the incidence of Butaro visits and breast biopsies increased in intervention health centers. The overall incidence of cancer diagnoses was not statistically significantly higher, though it was non-significantly higher. But we did see a statistically significant increase in diagnoses of early stage cancers, very promisingly and similar to what Sangiso has seen with his intervention as well as an increase in the diagnoses of benign disease, not surprisingly, since a relatively small proportion of our cases were benign. So what we kind of learned from that was that implementing a breast cancer early diagnosis program in these rural health centers staffed by nurses was feasible, and that it could have an impact on increasing diagnoses of early stage breast cancer. So there was a lot of interest in scaling up this program to other districts in Rwanda, and we had a lot of discussions with Ministry of Health, and in particular Rwanda Biomedical Center, which is Rwanda's main health implementation agency, about how to do this. Because of all the points that Anna brought up about the double burden of breast and cervical cancer and trying to use health systems efficiently, there was a lot of interest in trying to figure out how can we address both breast and cervical cancer together. So Rwanda Biomedical Center launched this women's cancer early detection program, which was a combined breast and cervical cancer screening effort. So in our first 3 districts, we did clinical, or the teams on the ground did clinical breast screening, clinical breast exam for any woman who was coming in for cervical cancer screening, which in these districts was VIA. Rwanda's protocol, as in much of the region, was to do VIA for any woman aged 30 to 49. And so the women coming in who received clinical breast exam routinely were also in that age group. In addition, we encouraged women, any woman who, we did the same messaging around signs and symptoms of breast cancer, and encouraged any woman who had any breast concerns to also come and receive a clinical breast exam, even if she was not eligible for cervical cancer screening. So this was launched in 3 districts of Rwanda. I think the combined catchment area was, it was over 1 million was the population. And there was sort of a staggered rollout in each of these 3 districts. So ranging from 1.5 years in Ramagana to about 15 months in Rubavu and 6 months in Kirehe district. And we looked at the numbers. I'm just using routinely collected clinical data. We looked at the numbers of patients who were seen, and sorry, this is visits, not patients. So over those time periods, there were a total of about 10,000 women who received cervical cancer screening, and a total of 17,000 women who received clinical breast exam. So we know that all women who were screened for cervical cancer, unless they declined, received a clinical breast exam as well. So there were about 7,000 additional women who received clinical breast exam without cervical cancer screening. Of these, about 4% had an abnormal clinical breast exam. About 600 were referred from the health center to the district hospital. And 75% of them made it to the district hospital. So we had a loss to follow-up rate of about 25% between the health center level and the hospital level. Of these, 200 were referred from the district hospitals to the referral hospital, which was most commonly Butaro. And then there was a loss to follow-up. So about 89% made it. So there was a loss to follow-up rate of about 10% between the district hospital and the referral hospital. So then we also looked, we had a patient navigator engaged in the project who helped us track patients who were referred to try to make sure that women actually made it and try to understand barriers to making it to where they were referred. I could give a whole other talk about our experience with patient navigation and what we learned from that. But she also was able to collect data on patients' diagnoses. So we overall diagnosed 29 patients with breast cancer over this time. They were all female. Very importantly, none of them were less than 30. A third of them were between 30 and 49. So that's a third of them were in the cervical cancer screening eligible age range. But 2/3 of them were greater than or equal to 50. So 2/3 of them would not have been eligible for cervical cancer screening. Also importantly, there were no patients who were diagnosed with breast cancer who had initially, so we looked into why patients had first gone to the health center to try to understand whether any of them had had a cancer diagnosed after just coming in for cervical cancer screening. None of them had been asymptomatic. 23 were confirmed to have a symptom. 6 were unknown, but all of them were diagnosed with large symptomatic masses. And so my guess is that all of them had a breast symptom at initial presentation. Very unfortunately, we don't see any, we see again a very high proportion of late stage diagnoses. So 79%, almost 80% stage 3, 4, and only 1 in 5 of these patients had stage 1 or 2 disease. We did interviews with community health workers, health center nurses, and then also administrators to kind of understand what this experience was like. And I'm not going to go a lot into these, but they had incredibly valuable insights into the value of training, the opportunity and the challenges of engaging patients. They described tremendous barriers that patients faced navigating their way along the pathway from initial presentation to referral, primarily financial barriers, including for transport, even more than medical care, stigma. And they really described very important challenges engaging older women in particular who didn't perceive themselves to be at risk of breast cancer, especially, and also felt that they didn't want to spend a lot of money on their healthcare because they perceived themselves to be, frankly, no longer valuable because they were no longer able to have children, and felt like they were also going to die at some point. So why spend money on their healthcare now? We interviewed patients as well. They described facing a lot of stigma and also fear around cancer diagnosis in general. So these were even patients who were not diagnosed with cancer had a lot of hesitation about initially being screened. They were overall pleased with their care, but described a lot of delays, including long travel and wait times at the district hospital and the referral hospital. Described a lot of financial barriers. And then we interviewed them during COVID, and COVID introduced tremendous barriers for them in terms of inexpensive travel. So it made travel a lot more expensive. It introduced significant delays in being able to go to higher levels of care. So we have learned a lot from this kind of early iteration. I think and so many of these lessons we're still kind of processing, but I think with regard to the integrated platform, to me, I think that having the integrated platform clearly allowed us to expand our reach and to reach, to engage women in breast cancer awareness who are coming in for cervical cancer screening. And being able to combine messages around both cancers, I think, can be really powerful and efficient. I think there are stigma aspects that they have in common, fear aspects, and knowledge aspects that they have in common. And so I think that can be a really powerful area of efficiency and synergy. Similarly, training, you can certainly leverage your healthcare training time period to do training in both cervical cancer screening and clinical breast exam screening. The content of those trainings is, of course, very different. A clinical breast exam is extremely different from doing visual inspection with acetic acid. Both have their challenges, but I think the skills involved in VIA and cryotherapy are more complex and also have more risks. But we did, and potentially there's synergy in the clinic time. So in other words, if you have a combined breast and cervical screening day, there is potential synergy there, though I do think that because they require different equipment, different procedures, different length of time, it's not a perfect match. And so it's sort of a partial area of overlap there. We did note a bunch of challenges. So I think the most important kind of take home from our experience was that it's not clear that clinically speaking, providing screening clinical breast exam to women who were receiving cervical cancer screening, it didn't, based on the data we have, that did not appear to lead to additional breast cancer diagnoses that would not have otherwise been detected. In other words, all the patients who we diagnosed as having breast cancer should have been picked up with a symptom-focused strategy, with an early diagnosis strategy. Where women, if women who had breast concerns felt comfortable and had accessible evaluation. Furthermore, importantly, the majority of our women diagnosed with breast cancer were older than the target cervical cancer screening age. So again, those were not those women we never would have picked up if there was a cervical cancer screening only platform. And this should be true, just knowing that the median age of breast cancer diagnosis in most of sub-Saharan Africa is about 50. So your typical cervical cancer screening program wouldn't catch at least half of those patients. I've heard some people, and maybe it was Anna saying this to me the other day, but that, although the median age at Butaro is 50, that might be a misrepresentation since we think that our older patients are less likely to engage with care. So we may be missing more cancers among older women. And then finally, I just want to address this issue of the really high proportion of late stage diagnoses we have. So first, in the very beginning of any program, it's not surprising to see a really high representation of late stage diagnoses because we're catching all this prevalent disease. We know we're finding cancers that women unfortunately have been staying at home with or coming into the health center and not receiving timely evaluation for. So that high number is not necessarily surprising, but it also suggests that we really need to focus on bringing in women who have symptoms of early breast cancer and also making sure that we are training our providers to identify those early breast cancer signs and symptoms, including with doing really high quality clinical breast exam. That is all I have, but I really look forward to the discussion, and here is my email address as well.
Thank you very much, Lydia. Thank you to everyone who's spoken today. These have been very enlightening sessions. I think that every country really needs to listen to this and begin to take steps to implement these in their healthcare systems. I'm just going to take any questions before we go forward. Does anyone have any questions? You can raise your hand and I'll unmute you.
I have a question. Couldn't find my, there is Amaka also.
Okay, so please go on.
So I go? Yeah.
Yes, please go.
Yeah, so just to Lydia and Sangiso, we haven't discussed, or you both mentioned it, but no one spoke, no one presented a project, only dedicated to really awareness, maybe you can have a cervical cancer program and then just spend some time with a woman that come to get screened to raise awareness about breast cancer in a meaningful way, not like we've done it in the past. So I don't know, I'd like to hear more about that, because this seems to be like a low-cost intervention that either it's been done poorly without getting to the, maybe without sending the right messages, or hasn't been done.
And I can speak really briefly to that, which is just to say that because of our experience in these first 3 districts, the Rwanda Biomedical Center now has scaled up to 5 new districts where they provide cervical cancer screening to women 30 to 49. And then when women come for cervical cancer screening, they do breast cancer early diagnosis education, and they do a clinical breast exam on women who would like one or have breast concerns. So it is an effort to find that place where you're doing meaningful education and targeting women who are at highest risk, which is one potential strategy.
So I think Amaka has a question.
Yes, I do. Thank you for the excellent presentations. It's just that I'm not sure whether we'll have the time now because we're just 3 minutes to the top of the hour, and we'll really want. But I think the presentations were great. Lots of food for thought. I was just concerned with something that Lydia mentioned when she was presenting, talking about the I think 25% loss to follow up. And that would definitely it's not something that's uncommon, because if you're linking the two, for screen positives, centers will probably just have maybe a thermal ablation unit, and they could offer point of care treatment at the same time. But for patients that come in with symptomatic or screen detected breast cancer lumps or lesions, they would definitely require further care. And that, I think, is where the problem really is, because then you can't have everything at one sitting and they have to migrate to another center. So I wanted to find out really, in hindsight, what do you think was the single most important thing that needed to be on ground at the time, so that, that percentage, the number of women that are lost to follow up would, we can bring it to the barest minimum. I'm not sure if there's time for this, but maybe perhaps in 2 sentences before we close out. Thank you.
So thank you. Yes, I didn't spend a lot of time on that, but that was our main target after this experience as well. So what we did, it was not realistic at these health centers to launch kind of a one-stop program, just because of the skill level of the nurses, as well as time and capacity and resource constraints. But what we have done subsequently is launched an electronic medical record specifically for women's cancer early detection that would allow health facilities to track patients through the system and identify when patients don't make it to their next level of care. So we're trying, and this is a very ongoing process that also would deserve a whole other talk, but we're basically trying to build capacity in those nurses to run reports and track those patients, and also empower them to address the barriers that patients face, because I think a lot of it was that there was a lack of information systems to follow those patients and identify the patients who did slip through the cracks. So I think information is one key ingredient, though it's not the whole picture. It's a great question.
Okay, so thank you very much, Lydia. And I think just to add to that, I think something else is, if it was possible to get a biopsy, sometimes if you started some kind of intervention, then you want to come back for the results. You want to know what the outcome of that intervention was. So that might be an idea, even though it wouldn't be easy to implement that. So I'm just going to hand over to Christine now to close the meeting, because we are at the end of the hour. Just to say thank you again to the speakers. Thank you, Anna. Thank you, Sangiso. Thank you, Lydia. This was really interesting, very enlightening sessions. If you have more questions, and I do see a hand up, but I don't think we can take it. I don't know whose hand is up. Mutungi, can you type your question in the chat box, please, if you don't mind, because we do have to end the meeting now. But you can reach out to the speakers directly to ask your questions. Thank you, everyone. I'm going to hand over to Christine to wrap up the meeting.
Thank you so much, Dr. Joseph, and all our presenters for the day. We have learned quite a lot and we are grateful. Discussions can continue on Basecamp. And immediately after this, we are going to send the recording once it's ready. And we welcome you to the next session. That will be on February the 3rd. And we'll be discussing translating cancer policy into implementation activities. And we'll be looking at palliative care in detail. So feel most welcome. In case you're not on our mailing list, please reach out to me or to Charles or to Amaka. Thank you so much. Over, back to you, Dr.
All right, everyone. So please reach out to the speakers directly if you have any questions. Again, like Christine has said, reach out if you would like to join the mailing list so that you can be aware of every meeting that's coming up. Again, very exciting session, and goodbye, everyone.
Thank you. Bye.
Goodbye and thank you.
Goodbye.